Hello everyone and welcome to today's webinar, From Rust to Trust with Jameed Billingsley. Our partner provider today is Advantage Support Services Incorporated. At this time, all lines have been placed on mute to prevent any background noise. We will have a question and answer period at the end of the presentation. You can type your question using the pane at the bottom of your screen. This webinar is being recorded and will be available on the partner YouTube channel within a couple of business days. Please note, there are no CEUs provided, but Jameed will provide you with excellent information. It's my pleasure to turn the mic over to Jameed. Sir, you have the floor.
Thank you very much. Thank everyone for coming and attending this training session. We're going to have some fun. It's going to violate a little bit of the rules of PowerPoints because there's going to be a lot of information on them, but that's because we're recording this video so that you can share with your fellow IPs or your surgical team or your sterile processing professional team. So let's have some fun. Before we get started, I want to thank CIHQ for being such a great partner in sponsoring this webinar. If you have any accreditation questions or needs, they are the ones to go to. If you're an IP that needs certification or life safety certification, they are excellent at that and great teammates. A little bit about me. I am a Navy trained surgical technologist and first assistant. I've been in the surgical field for about 34 years, and I know you're thinking, but you only look 34. Thank you. We're going to have some fun. I fell in love with sterile processing, and after I fell in love with sterile processing, I fell in love with infection prevention because sterile processing is essentially infection prevention. So I partnered with IPs until I learned enough that I became a certified IP. So I really enjoy IPs, and we're going to talk about how we can work together to fix our surgical instrument quality. The presentation objectives are we're going to talk about how damaged instruments affect SSIs. We're going to identify methods for IPs to understand the roles and challenges in sterile processing and tools for them to evaluate their sterile processing departments and related areas within the entire instrument cycle. We're also going to emphasize the significance of rounding and quality audits and enhancing instrument quality. We're going to talk a little bit about how instrument tracking systems can help us with that. And then we're going to recommend strategies to build better relationships with instrument repair vendors for the purposes of quality improvement. All right, so wait a minute. Are you saying that surgical instrument quality affects SSI rates? I'm actually not saying that. A great study by the widely known infection preventionists Rotula and Weber prove that. And so when we talk about instrument quality, we talk about the condition of the instruments, not just bioburden, but rust, pitting, damage, corrosion. All of those are great hiding areas for pathogens. Pathogens can get, when you have damaged instruments, pathogens can hide in there and they cannot be cleaned or disinfected from these areas because of lack of exposure to the sterilant or disinfectant process. So just keep that in mind that surgical instrument quality and SSI rates are very much connected. So what's the impact of damaged instruments on patient safety? So when you don't have quality control of the surgical instruments, first of all, you get a lot of frustration from your physician partners, right? But the other thing is the training that we have for our sterile processing technicians is not standardized. It's not like nursing. It's not like people who have their masters in public health or any other role in surgical services, including circulating nurses and surgical technologists. The training varies at each site. And so typically, quality control of surgical instruments is not a typical part of the orientation. It's more of a how, not so much why. So that's one of the keys to look at the education process and see where quality surgical instruments is as an IP at your facility. And so you can look over that and say, does this have any elements that would talk to us about surgical instrument quality? And so we talked earlier about how rusted or pitted instruments not only affect the functionality of the instruments, but that it's a great place that can harbor microorganisms, and we don't want that. So what do IPs have to do with surgical instrument quality? Well, when you think about surgical instrument quality, it is the overall rating of the state of your instruments at any given time. So what it means is it's not just those bad cases, because there's several times that when we do quality audits, we find instruments with damage that were not identified by our surgical staff. So the surgical staff cannot be the only catch for surgical instrument quality. Uh, Although IPs are typically not the primary leaders in sterile processing, IPs are very familiar with quality from their work around the organization with CLAPSI and CAUTI and those kind of protocols. And so, as an IP, how can we equivocate those protocols that we established for CLAPSI, CAUTI, and any other projects that you have going on in your facility to winning strategies for sterile processing? IPs are integral to the facility's oversight and quality initiatives. And our case studies at Advantage Support Services have noted that when you have high rates of surgical site infections, there's typically not a formal quality program. So that's where IPs can help, right? So how can we establish a formal quality program? Because think about the key KPIs that are being reported to you right now. Oh, our IUSS rate, or how many loads we ran without a positive biological. What do those have to do with surgical instrument quality and really patient outcomes? So start thinking about that as we talk about implementing a quality program. IP can also leverage their insights from other departments. We talked about CAUTI, we talked about CLAPSI. There are several other initiatives that you are the experts on. And how do we make those actions that we determine will reduce the patient risk into key performance indicators and develop action plans? This is where IPs can help. And oversight involves ensuring that the organization has well-defined policies. Do you have policies in place that focus on surgical instrument quality, right? So look at your policies and SPD and say, where's the part that talks about surgical instrument quality? And a frequent concern that we at ASSI, Advantage Support Services, encounter when we're assisting facilities cited during accreditation or following a CMS inquiry is lack of oversight. And so a quality program can be a part of that oversight and evidence of compliance. So what about the instrument tracking system, right? So we know what instrument tracking systems. Instrument tracking systems are the tools that we use to track our instruments from the last patient to the next patient. So it has other benefits for the team in sterile processing, but that is the main mission of an instrument tracking system. We know that AMI, CMS, all those organizations, AORN, talk about being able to track instruments from last patient use to next patient use. If you don't have an instrument tracking system, that's hard to comply with, right? And so in facilities that lack ITS, the IP's role can be helping justify the importance of an instrument tracking system. So in other words, no matter how big or small you are, there are several instrument tracking systems. And if you have questions about that, we can talk about that offline because we're vendor neutral, but we know which ones work that are affordable and modular so everyone can get it. Because really, going back to how can you track surgical instruments to patients, it's very difficult to do without an instrument tracking system. Also, when you start talking about root cause analysis for SSIs, so what if all the SSIs that you had last month in your department, all the instruments went through one washer, all the instruments went through one sterilizer, all the instruments were done by a specific sterile processing technician? If you don't have an instrument tracking system, that is impossible to identify. So as an infection preventionist, when you're looking at the root cause of SSIs, instrument tracking systems are crucial so you can identify trends that might contribute to the presence of SSIs. And so one of the other things is instrument tracking systems, a lot of times they come out of the box, and facilities don't progress from using the out of the box version to the advanced capabilities that instruments tracking systems already have built into them. And so by being an IP asking questions, you can kind of spark that and help them. The other thing, this is a study, write this one down. Studies have shown that when IPs have access to the instrument tracking system, it can kind of fast track that improvement process as it concerns surgical instrument quality. So one of the things that we recommend when we go into a place is allow the IP that's assigned to surgical services, whether it's OR, sterile processing, or both of them, to have access to the instrument tracking system so they can go around in there and learn how to run reports on their own, and then they can ask questions that can lead to process improvement. Another tool that we need IP's help with in the sterile processing community is customer surveys. We don't like to take customer surveys. It's just a human thing, right? We don't want to hear the complaints, but part of your goal as an advocate for patient safety, as an IP, is to help your sterile processing professionals understand the importance of a customer satisfaction survey. One of the things that I remember from my early leadership journey was I spent a lot of time concentrating on the things that I thought was wrong with my department and not nearly enough time concentrating on the opportunities that our customers identified. And so our customers are closer to the patients. And so if we can solve some of those issues, then a lot of the issues that we still have to work on our department should come after that. So when you start prioritizing which things deserve an action plan, customer service surveys are excellent for that. The other thing about customer service surveys is that they can become a KPI. So we do it every quarter or every 2 months so we can track our improvement right at the patient bedside. So that's one of the advantages of using a customer service survey. And as an IP, you can help your sterile processing team develop and feel more comfortable doing that uncomfortable action of customer service. So the other thing is, as an IP, we always find that there's pushback sometimes in surgical services with IP. I know, I can't believe that, but surgical services is not always as friendly to our infection preventionists as we should be. And so one of the things that I always tell IPs is you don't have to be an OR nurse or a surgical tech or a first assistant or a sterile processing master of disaster to contribute, right? But here's some tools that can help you get to know the standards and regulations and guidelines a little better. Look at CMS. Obviously, no matter what you're accrediting body, it's all deemed by CMS. Look through AMI. Look at AORN. SGNA is a great tool. And then the webinars, like the one you're attending now, there's several other webinars that you can sign up for. Beyond Clean comes to mind. The HealthMark webinars come to mind. And CIHQ does a great job with their webinar series. So you can just become more familiar with the area, right? And don't forget to buy SPD cookies for SPD week. Don't forget that. That is a key tool for the process improvement. The most important tool that we have in our toolbox is rounding. And you may say, but when I get ready to round, they always say I ask too many questions. Rounding always starts off as an educational process, but the more you round, the more you know, and then you can become that agent of accountability, right? We saw that stain on the ceiling when we rounded in January. When we round again in March, is the stain still there? So developing those rounds with not just you, if you come, that will encourage the OR to come, that will encourage facilities to come, that will encourage EVS to come. And you have better relationships with those departments other than the OR than SPD typically has. The other benefit of rounding is it can help identify some gaps and obstacles in the instrument improvement strategy. And then visiting OR and SPD is just one of the several vital activities. Don't forget about your ancillary clinics. We know from an accreditation perspective, the entire instrument cycle is under scrutiny. So it's not just the actions and activities going on in sterile processing and OR. You can take just as bad of a finding in wound clinic, L&D, any of your clinics. So include those areas in your roundings. Case studies prove that IPs can positively impact SPD quality by partnering to round to all the areas. So that's one of those things. Don't forget about all the areas, but rounding is a great learning opportunity and a way to check on the action plans that you put in place. So let's go to each area, and this is not an inclusive list, but we're just going to talk about some things that you can provide and look at as you're rounding as a infection preventionist, rounding to the areas of the entire instrument cycle, right? So after the instruments are sterilized, they're used in the OR. So let's start off in the OR, right? And one of the things that OR staff often complains, when I was an OR team member, I used to complain about is all this point of use care that we always keep talking about, point of use treatment. I don't have time to do that after the case. We're trying to turn over because it's pressure to turn over. And I agree. But here's the thing. APIC, AORN, AMI, and AST all talk about keeping the instruments in a state of next use during the entire procedure. So if you do the instrument treatment tips, because, you know, in the Navy, the surgeons were not so nice if you handed an instrument back that hadn't been removed the debris and bioburden and prepared for next use. So part of that is making sure that that's a part of the entire procedure, not just at the end of the case, right? And then when we're doing transport, are we putting the heavier instruments on the bottom? Are we transporting in a leak-proof device that can be marked as biohazard? If you're using open case carts, they have to be closed to prevent aerosolization as they roll and hit the bumps and go over the elevator. And those are the things that you as an IP can say, hey, I have questions about this process. Next, we can go to IP and talk about instrument quality, right? So make sure that the staff is rating every instrument tray before they start cleaning it up. A lot of times in SPD, we rely on the shock picture method. Like if something is really bad, we'll take a picture. But what we lose sight of is if we did 55 cases and only got 3 pictures, that's not a bad ratio. But there may be some other problems, particularly stacking and the loading of the cart that doesn't rate a quote unquote shock picture, but may do more damage to the instruments, right? Also, enzymatic cleaning solutions, right? Are the dispensers for those, a lot of places have automated, are they being tested to make sure they're dispensing correctly? If you put too much enzymatic, it does not clean the instruments better. It actually clouds the water and prevents you from seeing what you're doing, and in some cases can leave more residue that can be rinsed off in the proper process, right? The other thing is the quality of water. Water, water, water. I was tired of water. I thought it wasn't going to be in this lecture. Actually, it is in this presentation. The quality of water has a big impact on both the steam quality and the residue that's left on the instruments and the same water that's used in the washer cycle. Another thing that we see all the time when we're doing rounds around the country is automated washers. A lot of times the instruments are being sent through the automated washers on the same load, right? Because nobody teaches us. But each different instrument category has different washer loads that will give it the best opportunity to be cleaned without damaging the instrumentation. Eye instruments cannot have lubrication or enzymatic in them. Orthopedic implants and orthopedic instruments often only have instructions for use that talk about no lubrication, right? So are we running those through? And those orthopedic loads will give us a chance at bioburden-free products on the other side. The next thing we're going to talk about is the instrument quality checkpoints in assembly, right? And again, as an IP, you're not doing this, but you can walk around and say, hey, where's these things, right? So the big thing, this is a revolutionary thought, is does your facility reward team members who identify defects? A lot of times in the operating room, we learn a surgical conscience that says, when in doubt, throw it out. And then when you ask SPD, how often do you reject stuff? How often do you say, nope, this needs to go back to the previous steps? And a lot of times our SPD team members are like, oh, I'm not sure. I'm not familiar with that thinking. We want to implement that thinking in our sterile processing because, yes, we have a lot of work to do. And yes, rework is frustrating, but if we can reject work, it increases the chance that we come out with a quality product, right? And then when we talk about the pads on trays, when you look at this picture, there is no pad on the tray. So a lot of times instruments get damaged from dumping because The process of assembling an instrument tray includes removing all the instruments from that tray so you can inspect and assemble them. Well, if you don't have a pad that's disinfectable, it increases the chance of damage to those instruments in that process. Overhead lighting. A lot of times we go into these romantic places, which is great for Italian restaurants, not so great for assembling instruments and inspecting instruments. Magnified lighting. A lot of times you have magnified lighting on each workstation, but it's not on. And one of those things is some of the details and the defects and the numbers on these instruments can only be read by magnified lighting, even if you have perfect eyesight. And several IFUs for certain instruments, I'm talking robotic instruments, other instruments, require that you have magnified lighting. So, and then function testing. So one of the things that we found is when you perform function tests, they can also identify defects and bioburden. So then, yes, it's frustrating you have to take the tray back, but at least you identified it before the operating room had to use the instrument. Here's some function testing. To the left is the scissor testing. In the middle is the testing for rongeurs. And then on the right, which we rarely see, is the testing for curettes and osteotomes. Make sure that your team has it. On the right is the recommendations from AMI for the amount of light that you have. There's apps that you can use on your phone and a very inexpensive lighting tester or lux tester that you can purchase from Amazon or any other place, Granger. I'm not sure if it's at Staples, but it's not expensive so that you can measure the light. When you get your lights into compliance, you start having immediate positive results from the inspection phase. And then you have the supplemental lighting, which are the magnified lighting, and to include borescoping. The other thing that presents a patient safety risk and was recently added to the latest update to AMI ST79 was laparoscopic testing for laparoscopic instrument or any coated instruments. And so you can see from some studies the damage that can be done for a patient during a laparoscopic surgery or any surgery that needs insulated instrument. So adding that testing and putting that on your count sheet as an attestation is a way to drive compliance and drive patient safety. And then the other part is when you're looking at instruments, which area of the instrument is most prone to damage, and that's the working end, that's the tips. So when you see team members inspecting the instrument, yes, you want to inspect the whole instrument, but you want to pay close attention to the tips because that's where the damage occurs, right? So now we're going to talk about surgical instrument packaging. So after we've assembled the instrument, we have to put the instrument in surgical packaging. And the instrument trays must be internally and externally cushioned with approved material that does not cause wet trays. So you have tip protectors, you have medical bags that are rated to be sterilized. Those are the acceptable implements. You also have silicone mats that can help you. When you talk about, we go to some places that have the metal instruments right on the metal tray because they've had problems with tray liners in the past and debris or kind of discoloration that we'll talk about from steam quality, and they go, oh, we're tired of getting called to the operating room, let's remove those. That can damage the instrument trays. Also, when you're padding the trays, wrap trays on the outside, make sure you choose the option that does not promote wet loads or wet trays. So make sure it's approved items. And so when you start talking about padding with towels, are those towels approved for that purpose? So, and there are devices. Also, are you using the thickest available wrap on your wrap trays, right? So wrap is not wrap. And so you have thicker wrap that's used for vendor trays, but sometimes you have heavy trays that are not vendor trays. So make sure you have that available. You can put on the count sheet, this needs a heavier wrap to give your team members a better chance to succeed. And also when you're talking about weight, holes in wrap, which contaminates the whole instrument tray, are closely associated with the design of the tray, but most likely the weight of the tray. So do you have overweight trays? We know that that's an OSHA and an AMI issue, but how do you know? Like Sometimes, some days I'm feeling weak and I'm like, man, this tray is heavy, and they weigh it and it weighs 10 pounds. And sometimes I'm feeling strong and I'm like, this tray is nothing and it weighs 30 pounds. You need to have a skill in decon to receive vendor trays and on a clean side to double check, right? And then again, back to our acceptance versus rejection protocol. Do we ever look at containers and say, I need a different container? A lot of times we're in a rush. We don't want to reject it. Do we have a seal around the gasket? Is the gasket intact? If you find yourself hammering rigid containers back in place, that's not a function of a sterile processing technician. So just look for those kind of things. But if you see a rubber mallet in the assembly area and you go, what is that for? That might be the purpose. All right, factors in the sterilization area. Right. Make sure that you're using validated methods. A lot of times there's software that can check the IFUs for you that you can program into your system so that you can't say, well, we need this in a rush, so we're going to put this in hydrogen peroxide sterilization, right? The other practice, holding instruments in the autoclave after a cycle is a ancient practice that was started to cover up wet loads, right? There is no IFUs for any sterilizer or instruments that require you to hold it in the sterilizer. If your team is telling you you're doing that when you're doing them rounds, it's because they've had some wet loads, which might be caused by the quality of the steam. So, which you should have an annual report of the steam quality. And when you start seeing staining on instruments, staining on containers, staining on the washer delivery racks, those are indicators that you have some water quality problems, and we need to get your sterilizer manufacturer will come in and do a no charge water quality test for you. So also don't forget, we're going through the whole sterilization instrument cycle. What about sterile storage, right? What are the risks associated with sterile storage, right? So instruments should only be handled by personnel who have verified competencies. What does that mean? I'm looking at you, vendor reps. A lot of times we go to place and they're complaining about holes and the instruments being out of order or shaken up when they're delivered. And then I watch vendor reps who don't have competency training, who don't have any training on how to handle the instruments after they've been sterilized. Oh, he's taking it up to the OR. No, the only people that should be handling instruments are people that are competency. So if you want to let your vendors take the instruments up to the OR, you have to make sure they have a competency and you have it on record so that they are not a source of contaminations. The other big thing that we see is use life versus shelf life. And so how long does the manufacturer say you can store the materials that are used to make a tray before you make a tray? And then once you sterilize that tray, how long does the manufacturer say it can stay on the shelf? I know a lot of facilities like to use event-related sterility, and I'm not going to get into a tussle or fight about that, but what I will say is, are you willing to have your family member have a tray that was sterilized 10 years ago, right? So we didn't have any incidents in 10 years. We've changed the trays 14 times since then. The person who did the tray retired 6 years ago. Is that the tray we want to have to represent our quality in sterile processing? You guys should, on an interdisciplinary team, establish a time period. I like 18 to 24 months that you just kind of start looking at those trays to undergo a quality check. The other part is, and here's where we need IP's help, is rounding to the other areas where instruments are stored and used and given point of use treatment. A lot of times when we talk about sterile items are stored with sterile items, clean items are stored with clean items, and you go into one of your clinics and there's a mismatch, and even you have some unsterile items or contaminated items too close to the sterile items. How are you going to know if you don't take it around? So you as an IP and with your partner as a SP professional, you guys should be going around and identifying those risks to surgical instrument quality, and then helping the sterile processing team schedule education and training and even competency for some of your busier places so that we can reduce that risk to both patient safety and accreditation. Because again, we're talking about the entire instrument cycle. And where we need IP's help is you guys have better relationships with those people in the women's and children's section, the emergency room, all those different areas. A lot of times those relationships are not the best with sterile processing, and we need you IPs to come in and kind of be the peacemaker and bring us together. The next step is talking about the IP's role in establishing a SPD quality program, right? So you are familiar from other areas with a CMS QAPI program, quality assurance, process improvement. Let's apply those principles to sterile processing, because after all, what CMS says is any area that has a high chance of errors that can contribute to poor patient outcomes should have a QAPI program. It's hard to argue against sterile processing having a CMS QAPI program, and so you can help them, because typically the SPD is talking about a quality program. They're like, we told you how many positive or negative items came out of the incubator in the biologicals. No, a CMS quality program is much more thorough than that, and they need your help because it is a condition of participation, and that's been a recent finding that we've found at a lot of the hospitals that we visit. So establishing or enhancing a surgical services interdisciplinary team. So when we ask places that we go, do you have an interdisciplinary team? They're like, yeah. Oh, okay. How often do you meet? Do we meet before Thanksgiving or was it after Thanksgiving? That's not an interdisciplinary meeting. Interdisciplinary teams need to meet on a consistent basis to address the issues, including surgical instrument quality, that can be improved through group efforts. When you get those teams together, one of the benefits is a fishbowl effect, right? So if you email the sterile processing leader and said, hey, did we get that towel changed in SPD that we found on roundings? Oh yeah, we were going to I think we sent an email to plant operations or facilities, and we're waiting to hear back from them. Well, when you have the interdisciplinary meeting, you can say, hey, what's going on with the stained towel? And then right there is the facilities team. And the facilities team say, nobody ever sent anything to me. Or they'll say, I'll get somebody down there right now. And I found that to be a great side effect of that interdisciplinary meeting. IPs can help with data collections. A lot of times when you're first starting a good interdisciplinary team, the OR is not going to attend because they had a fire. Then the next team, SPD, had a call out and they can't attend. And then the meeting is canceled. But if you record the minutes from that meeting and continue that meeting, even if one of the members, then sometimes they'll be able to come in maybe 15 minutes late. But if the meeting is canceled, everybody's like, phew, and the process improvement stalls, right? And so IPs really help SPD leaders shine because they can be kind of like the reminder, the facilitator to say, are you ready for the meeting next week? I don't have the data yet. I don't have access to the instrument tracking system yet. That's where IPs really can shine and help them with that process. Now, quality auditing instruments. I know a lot of times it's great when IPs are quality auditing instruments, but here we're talking about IPs looking at quality audits, right? How can you help your SPD have more effective quality audits? The first mistake that you can help them avoid is we audit every tray. If you're auditing every tray, as our results have shown during our studies, you're not auditing any trays. You need to identify the trays that have a high chance of creating poor patient outcomes and concentrate on those, right? And avoid self-selection by the SPD staff. When I was first starting quality audits, my team, I was like, man, the numbers look great. And then I realized, man, they were really QA in that minor tray. And that wasn't a tray that we had any errors on. Develop a clear audit checklist that everybody agrees on that we're using to make sure that our tray audits are good. And then here's the big part that IPs can help. We have customers or clients sometimes, and we go like, what are we doing with our quality audit results? And they're like, oh, we just store them. No, we need to report them to surgical services and at the system-wide infection control meeting. Again, the fishbowl effect will help us start making progress and identify some patterns that may be impacting our patient safety. The next one is RCA should be performed. So if the same trays or the same errors Let's do a RCA and figure out why we're having those repeated errors, develop some training, and update the count sheets. Quality audit should be reported in the multidisciplinary or interdisciplinary team meetings, and HR should be consulted to develop a just culture that focuses on education that progresses to discipline if we have specific team members that are having trouble meeting our standards, right? And here's the most important. The instrument maintenance should be based on quality audit results, not a computer-based interval established by the instrument repair company. We're going to talk about how the instrument repair company, a lot of SPD departments leave the instrument repair company to tell them when items should be examined, inspected, and maintained by experts instead of the results from their quality audits. High risk trays. What are high risk trays, you say? Well, a lot of times the high risk trays go with the type of surgery. So cardiothoracic instruments are high risk because the surgeons are using loops the whole time so they can see any imperfection. Neurosurgery, they're using the microscope the whole time so they can really look at those instruments as they come in like a great white shark into the surgical field. And laparoscopic surgery and flexible scopes, again, you have enhanced video that magnifies the field and any perfections and debris that may be on that instrument, right? So how do we reduce instrument damage risk by addressing hidden issues, right? Here's a couple of hidden issues that I want you to look at next time you go to your sterile processing department, because that's what we're doing after this presentation, right? There's extra drawers and instruments hanging on the wall, right? And so we know when instruments come out of the washer, they're not sterile, they're disinfected. So that means they don't have a zero instrument count, especially on spores, right? So if I have an instrument sitting in a drawer or hanging on the wall for a period of years, just by binary fission, any residual microbial will expand and expand and expand, not to mention how many people touched it, right? I touched it here. I moved these instruments to get that instrument. I moved these instruments around the drawers. And we recommend that instruments be stored in a HEPA filtered cabinet that prevents people from using it and outside contamination to reduce that risk. And nevertheless, instruments should go back to the decontamination site before you add them to the tray. Another accreditation risk, right, is instrument marking with tape. I'm here to tell you, you don't want to argue this point, right? I want the interdisciplinary team should meet to consider the previous and very public instrument marking tape accreditation issues that have stopped surgery and all that stuff. And is that worth the risk that goes along with it? Because when we think about why are we marking the instruments? To make it easier to put them back in the same trays, or to make it easier to identify, or make it easier to put it together? That sounds like an education and training issue, not a surgical quality issue, right? The surgeons don't need the instruments marked with tape. And again, is instrument tape illegal? It's not. But if you get cited during accreditation, and you say, well, this one is we mark our instruments, but we have to document how often we change it and how we're complying and how you inspect it. But they still can just open every taped instrument, and if they find one, which on this the picture that I'm displaying, I see about 4 of them that don't meet the standards. Then it can go to a immediate jeopardy or conditional finding, depending on which survey accreditation survey you use. But again, check to see if it's worth the risk, right? Because the surgeons don't need it and the patients don't need it. So who are we taping the instruments for is always my question. All right, so part of your quality improvement plan for the condition of your instruments is working with the instrument repair vendor. And typically, this is not an area where IPs are comfortable contributing, right? But let me tell you why we need them. A lot of times, the relationship between an instrument repair vendor and SPD can become too cozy. The instrument repair vendor comes in, they take the trays that they determine it needs to be sharpened, and they have a cozy relationship. and the surgeons are yelling like their hair is on fire to the C-suite. So if that's happening, the relationship shouldn't be that cozy. And here's how IPs can help, right? So you can um, help your sterile processing leadership manage the instrument repair vendor, right? And so part of you helping to manage it is complying with the CMS performance management of vendors and accreditation, right? And you know this, and a lot of times it's not applicable to sterile processing, right? Because you talk about the dialysis machines and the equipment maintenance that's required all around and the performance metrics, right? So you can help talk to your sterile processing partners about developing the criteria to meet the CMS because this is not just a contract, it's one of the biggest contracts in your hospital. And SPD could benefit from your help. We talked about the high risk instruments earlier. These same instruments need more maintenance, right? Because you can't say, oh, we're equal. It's time to sharpen or maintain this instrument tray. This instrument tray is not a patient risk. You haven't had any complaints on it. So we want our vendor repair teammates, partners, concentrate on the trays that we've had significant issues with. Here's some questions that you can ask your sterile processing leader. And if you're a sterile processing leader attending, ask yourself or ask your whoever managed your contract. How long is the contract? How many trays per week you need to have maintained based on the errors that you've had, the high risk trays, and then the low risk trays. Can you do other methods like replacing the scissors, replacing instruments that get damaged instead of sending a whole tray out because it may not be as much risk as some of your high risk trays, right? So again, you IPs didn't think that that was something you could contribute. You have the expertise, and just by asking those questions, you can help your team members do a better job. In summary, uh, we have the absence of a quality program, or if the quality program your sterile processing has is not robust enough, IPs are a great partner to help you fill in those gaps, right? Because a lot of time your sterile processing leader doesn't know exactly what's missing from that program. And so you can watch this presentation with them and start asking some of those questions. The IPs can be a part of that interdisciplinary team that becomes all high reliability organization has someone who has questions about everything. IPs are a great person to play that role. Um, Reminder IPs, you don't have to be experts in surgery or sterile processing to offer that meaningful support. Your relationships with the other areas in the hospital that are a part of the instrument cycle that a lot of times get left out of instrument improvement are invaluable. And when you do rounds, I promise you it can add quality to this process and improve your surgical instrument quality while reducing your surgical site infection rates. Now I open the floor for questions and answers.
All right, Jameed, let's look at the question and answer period. Let me pull this up. Looks like you've got quite a few in here. Let's see. Let's see. The presentation will be available. Yes, Gwen. It's also in your registration email, but I can send it to you. The same for you, Jessica. The slides will be made available. At our facility, we use an enzymatic solution that is sprayed on instruments after use. However, during observations, I noticed that it was only applied to some surfaces. Is it necessary for all instrument surfaces to be fully coated with enzymatic spray, or does partial coverage still provide adequate protection?
Thank you, Anonymous. That is a great question. A couple things. One, enzymatic spray, um, you may have to do a risk assessment of using enzymatic spray versus those other sprays that are made of surfactants, because it delays the start of the spraying. You really should not be using enzymatic spray until the patient is out of the room and everybody in the room still has on their eye covers. And a lot of times, what we see is people either removing their mask, depending on facility policy, or their goggles. So enzymatic spray may not be ideal because it kind of delays the application, and so we get rushed, and then that's kind of tied into that incomplete application. Whereas surfactant sprays can be applied as soon as the wound is closed and the dressing is applied, so it gives you a better chance. Obviously, the answer is all surfaces need to be covered for it to have the effect. What we're trying to do is prevent biofilm, which starts forming very quickly after use. That's why we want to use point of use treatment during the case. And so if you don't apply it, the areas that are not touched by whether it's enzymatic spray or an instrument spray that's surfactant are still undergoing binary fission, and biofilm is getting stronger and stronger, making it harder to clean off and potentially permanently damaging those instruments. So what you want is full coverage regardless of which solution you use.
Thank you, sir. Next question is from Stacy. Can you share your knowledge on water spots? This is a challenge we are facing. According to our water testing based on Table 2 of AMI ST 108, our water quality is not an issue. What are we missing?
That is a great question, and my partner Angela Llewellyn, who is the leading water quality clinical person, and we learned a lot when we were helping write ST 108 as members of AMI. So there's other factors, right? Are you using the correct detergent ratio in your washers is probably where I would start, right? We assume that they're programmed correctly. Having a third party independent assessment of that, or just frankly asking your washer vendor to come out and test to make sure that they are still set at the proper levels and dispensing the proper amount of detergent, right? Enzymatic and lubrication. So there's several chemicals and solutions that are in that washer that could be a part of that those spots that you're seeing. The other thing is when you're looking at your water testing table, table 2 is just one of the tables in ST108. So make sure you're looking at not just the pH, but all the different elements that could be a part of your water, and make sure you're doing more than one water test. So remember, the municipal supply of your water changes at different times of the year, right? Based on the water source that's better for the city or the area that you're in. So your water quality test might be before we change from mountain water to, say, well water or whatever the municipal water supply is. So make sure it's easy to contact the municipal water provider and find out when they change so that you can have water testing on both. But also, you want to rule out the solutions that are applied during the mechanical automated wash process.
Thank you, Jameed. Another anonymous question. I observed a mallet, possibly called Thor's hammer, with multiple dents in it, which I assume was normal wear and tear for that type of instrument. At what point does an instrument like this become unsafe? Are there specific criteria for when it should be removed from circulation and replaced?
This is a great question, and one that is a real part of the kind of debate in the industry right now. So obviously, as soon as you take a new mallet out and wash it properly, sterilize it, put it in a tray, that second after it's used is going to have impacts to the head of the mallet. They're designed to withstand those, right? But to your point, you can't have a mallet that's 28 years old and still say, no, it's good. So a part of that is managing those products in with your instrument repair vendor. mallets are one of those things that should be inspected by a third party or repair company to ensure that it's still good for use. And that can be documented in your instrument tracking system so that if any questions come up, we can say, oh, yeah, this mallet was inspected and it's good to go, right? So, but every mallet is not good to go because damage is not damage is not damage because it's not an indestructible, right? I know the Thor's hammer is not really from Asgard. That's a little shout out to the nerd in me. It was made here on Earth, so it doesn't have an infinite timeline that it can still be used. So those need to be inspected on a more consistent basis than other items that are not full of dents and impacts and potential areas that microorganisms can hide if it's not still functional.
Yes, and Lorraine Perkins added a little more information as well. When assessing the safety and usability of a mallet like Thor's hammer, several factors should be considered to determine if it has reached a point where it should be removed from circulation. Some criteria to evaluate: physical damage, look for cracks, deep dents, or chips in the head or handle. If the integrity of the mallet is compromised, it can break during use, posing a risk of injury. Material fatigue. Over time, materials can weaken due to repeated impacts. So, thank you, Luane. Another anonymous question: how often should our facility have our SPD departments assessed?
That is a tricky question because what I am advocating for you as an IP to be a part of that assessment, right? So I would look at, and again, this is not me trying to sell product. This is me saying you want to be prepared for accreditation, but also to deliver the best patient safety. So maybe annually, every 2 years, you should have an outside team assess your department, but every quarter, at least every 2 months, you should have an internal team, interdisciplinary team that includes IPs and the people that can fix the problems like EVS, like facilities, like the operating room should be doing rounds in the department on a consistent basis to identify low-hanging fruit and easily fixed problems prior to and between having a third party come in and take a look at your processes in your department.
Okay, there's an anonymous request for the slides and the information. Will you please send me a private email so that I'm able to reply and share the slides? You're anonymous, so I don't know who's asking the question for them. Connie Compton also gave additional information about inadequate coverage of enzymatic solution. It does not break down bioburden. All surfaces should be sprayed, as you said, Jamid, and remain wet until decontamination occurs. A question from...
Great answer by my friend Connie. Great answer, Connie.
Yes, yes. A question from Monique. For packages of sterile instruments that have no expiration date, how long are they good? We have instruments that have been packaged years ago, and as long as they are intact, no watermarks, and not opened, we keep them. Should we add a receive date on the outside of the packages or put an expiration date on them? Does that alter the sterility?
So the label doesn't do anything to the sterility, but what you should consider is what your internal policy is, right? And so there are alternatives to labeling instruments packages, but the problem is, can you track that back to its sterilization source, and how can you track that to a patient? So if you have packages without labels, that's an issue. If you have packages without expiration date, I would recommend moving to a label that says event-related sterility as long as everything is intact, right? For both survey purposes, training purposes, and so that if anybody is getting ready, the end users are like, is this expired or not? The other thing is to make sure that your rules are not made up in your head. In other words, the rules have to match with the IFUs for the packaging systems that were used to seal the trays and the lowest risk for the patients at the end. So I hope I answered your question. If they are intact and no watermarks, you can obviously keep them. But at some point, if it's a year ago, 10 years ago, how long would you keep them and feel comfortable using them? Because as we know, the training is better than it was 10 years ago. The webinars are better. You got Connie and Michelle Schaefer from CIHQ that are better. So again, just make sure that your internal policy says that, and that the labeling on the packaging makes it clear that you're using event-related sterility, but that still doesn't free it from needing having a quality process that looks at those things that were sterilized long ago and seeing if we need to repackage it. Is it still within standards, and is it going to be safe for patient use?
All right. Luane contributed a little more to your Amy ST108 question. If your water testing indicates that the water quality meets the standards outlined in Amy ST108, but you're still experiencing water spots, consider the following factors that might be contributing to the problem: hard water, water temperature, drying conditions, cleaning agents. The use of certain cleaners or detergents can leave residues that contribute to spotting. So Melinda asked, what does it mean when white liners being used at the bottom of the instrument baskets are showing stains and discolorations after sterilization?
Never heard of this Melinda person. Hi, Melinda, one of my best friends in the industry. So again, we were talking about when facilities remove the white liner that's validated for use in the trays because they're getting too many stains. Um, what Melinda is talking about is those stains indicate a problem with the process. So removing the liner doesn't fix the processes that created the stains. We talked a little bit about residual improper rinsing, too much detergent, the quality of the water you're using, and the quality of the steam that's going to the sterilizer. Any of those five things and even more can be the cause of those things. So, one, it is important to pad those trays with something, right? To keep the tips of the instruments, the most delicate part of it, uh, intact. So removing those white liners solves an irritation but doesn't solve the problem. So what we recommend is if you're getting those stains, calling the experts, calling companies that can help you with that, right? Who have an industry-wide reputation to help you with that, rather than just taking the liners away, which are going to start causing damages to the tips of the instruments, and also whatever was causing those stains is still going on. Great question, Melinda.
All right. Ms. Sharon, no, you don't get continuing education credits for this, but it is excellent information to have in your back pocket. You can access the recording on the CIHQ ARS Partner YouTube channel. It should be loaded within a couple of days. Another question about hanging instrument storage in a HEPA filtered cabinet. Is this before or after the instruments have been sterilized? If it's after, would you need to remove the instrument with sterile gloves?
So that is a good question, right? One of the things that I like to say is if there's any place that we want to use gloves on the clean side, it is when we're retrieving those instruments. A HEPA filter cabinet is not a requirement. It's not a requirement. When we're talking about instrument safety and reducing SSIs, what we're sharing methods that can reduce the risk, right? So a HEPA filtered cabinet is less risk than just hanging it in the open to environmental conditions and all the shedding that all the humans that work in the department have, all the dust, right? So you don't need to sterilize the instruments. Sterilized instruments should be stored in a different area. But that is funny because I didn't like hanging instruments. All my extra instruments, I would rather have them sterilized because one, a lot of times the last minute emergency use is not to add the instrument to a tray, but to add the instrument to a room that wasn't in the peel packs upstairs. So then we don't have it ready if it's not sterile. So I like sterilizing instruments when I can, but that's not a requirement. It's just one of those things to reduce the risk and save the quality of the instrumentation. So they don't need to be sterilized, and you can handle sterilized instruments without sterile gloves, right? So the pictures that we show were non-sterilized instruments, instruments that have been low-level disinfected through a washer of some type.
Okay, lots of excellent presentations and compliments. Another question, how long are enzymatic sprays good for?
So every spray, whether it's enzymatic or a surfactant, has a claim when they got their clearance from the FDA. So there's no universal time. Look at your manufacturer's instructions for use, and it will tell you about how long it's good for. But that does bring up again one of the things about using enzymatic versus surfactants. Surfactants just have much longer um, dwell times that are going to keep the items moist for up to 72 hours. That's pretty much the standard for surfactant types. The enzymatics are all over the place, but that's not how they work. So a lot of times they won't have any claim about how they're long they're going to stay, because their purpose is to start eating the proteins on the instrument right before you process it. So again, check your IFUs. It will have a time, but just in general, the surfactant types have a longer moisture time than the enzymatic sprays, if they have any.
All right, great presentation. Any that came late, just email me, please, Michelle Schaefer, and I will get you the presentation and access to the recording. Let's see. Fantastic presentation. Derek, email me, please, and I will get you slides. Monique, the same. Enjoyed the presentation. Stephanie, I will email slides. Security reasons. Okay. Anonymous, I'm looking for SPD education for infection preventionists. Can you provide reputable options that don't break the bank? Anonymous, with that question, if you email me, I'll connect you with a couple, and Jameed, I will connect you with them as well.
Thank you.
Melinda, peel pouches, time is an event. See what the manufacturer's post-sterilization storage test time was. Lots of great presentations. Connie, what is the definition / indicators for determining high-risk instrument trays?
That's a great question. There's no universal high risk other than to know that orthopedic instruments have a higher bioburden and cement retention than any other instruments. We talked about the other instruments being high risk because they're performed under magnified lighting, which can can emphasize any flaws that you have. I think high risk instruments are determined by the instruments that you have had trouble at your facility processing. So when you have your reactive quality audits, your complaints from the operating room, which instruments and instrument trays are those? Plus looking at doing an FMEA, which instruments are in that family. So if I having problems with a small fracture tray, then I'm probably going to have problems with a large fracture tray. So those are kind of when you finish your RCA, the next step is to go into a FMEA to say what else is in this family, so we can add those to our high risk instruments. Again, there's no universal high risk instruments. A lot of it is based on the design of the instruments and the results you're getting. Thank you, Melinda, for that additional information about pill pouches. Obviously, I agree with that.
All right. For any who are not able to access these slides through the link, please email me. And let's see, great presentation. That's the end of the questions in the queue. You have Jameed's contact information there. Thank you for putting that up, sir.
Thank you
And
for the
again,
reminder.
you got it. You got it. All right. I've got the participation list. I'll get that out to you, sir. And everyone have a great afternoon. Enjoy the rest of your day.
Before we go, thank you again, CIHQ, for partnering. Thank you, attendees, for coming. If you have any questions that you think of after you rewatch this, here's the contact information. This will be a part of the recording and a part of the presentation deck. Reach out and you'll get the expertise not just from myself, but you see Angela answer a few questions. You see Luane answer a few questions. We have several SMEs on our team that can answer questions, and we want you to have the safest patient outcomes with surgical instruments.
Thanks, Jameed. Have a great day, sir.
Thank you.